Welcome to Cancer Conversations with OHC. I'm your host, Joan Manzo, and I am extremely excited to have Dr. Marcia Bowling, one of our noted gynecologic oncologists, with us today. Welcome, Dr. Bowling.
Thank you. Glad to be here.
Great to have you. So we know that January is Cervical Cancer Awareness Month, and that's going to be the topic of our conversation today. While we are seeing a decline in cancer incidence, very recent studies are showing us that there still are relatively high percentages of cervical cancer, and that it's increasing in women age 30, in their early 30s, and that it's killing more women over the age of 65. It's my understanding that this disease is preventable, and so I want to get started with asking you a couple questions. What are the tools available that we have to prevent cervical cancer from occurring?
Well, at first I will support what you're saying, and even of note in my practice over the past year or so, I have seen many more patients come in who are young with cervical cancer, and so it is certainly true, and we've seen it. We've always had the tools of screening, and that's the pap smear, and then early identification with an abnormal pap smear or carrying certain strains of human papillomavirus, which I think we'll get to in a moment. And we have vaccinations. So those are all tools that have been available. So why aren't they working the way they did? And I think this is there are multiple reasons. Of course, I think that people can get complacent as they start to hear about less people that they know having precancerous conditions of the cervix or cancer. Then it sort of falls off the interest level, and they just don't go and get injected their vaccines. They don't go to the doctor for pap smears. The pap smear recommendations have changed recently, and is this a ramification of that? We don't. It hasn't been long enough that the recommendations for the frequency of pap smears that we're now doing has been enforced. I think there are always the usual barriers of economics and availability and education that are always going to be barriers to getting access to these preventative measures. But in addition, is there some component of vaccine fatigue? Every time you turn around, you're being told that you need this vaccine or a booster or whatever, and maybe people aren't just getting HPV vaccines, they're sort of pulling back. And the other unfortunate issue, I think, that we could be seeing ramifications of inability to go to the doctor for a couple of years. So people couldn't get their full series of vaccine, or they may have had an abnormal pap that didn't get worked up and kind of got brushed aside simply because you can't do a televisit to look at your cervix.
Good point. Yeah, I think that we're seeing across the board the impact of COVID and the lack of screening that's occurred for the last several years.
Right.
Excellent points. Let me ask you this, just for our viewers. We know that the main cause of cervical cancer is the human papillomavirus. And I want to get into the vaccine that you mentioned, because a couple years ago they expanded the age range. But how important is this vaccine, not only for young women, but also for boys as well to get at an early age?
Right. So cancer of the cervix is most of the time caused by this family of viruses, human papillomavirus. There are only certain strains of the virus that are considered oncogenic or potentially causing precancerous conditions that can ultimately evolve into a malignancy. There are many strains that are not, but the vaccine that has been targeted toward those strains of the virus that are cancer causing is very effective. The trick was to figure out what age group needed to be inoculated, and they started off looking at a population that was unexposed from sexual activity, and that's why they went into such a young age group, and of the 11-year-olds to start the studies, and they sort of approved it for use in 11 to 20-ish, 22-year-olds. But since then, of course, it's been expanded because women are sexually active, are exposed to new contacts much later in life. Excuse me, and so therefore they've extended the range of women who can be vaccinated. The other thing that's important is that because a woman has had HPV or dysplasia doesn't mean that she still shouldn't get vaccinated if she hasn't been. I think a lot of people think you know, well, I've had it, so I'm immune, or I don't need to worry about it, or the damage is already done. But, you know, we might have cured one issue and then there's another exposure, and if she's not vaccinated, it's still important to go ahead and do that.
That's an excellent point. So really the vaccine can be administered by a primary care physician, a pediatrician, their gynecologist, or they could even make an appointment with a local pharmacy to get
Correct.
the vaccine.
It's easy to get.
Okay, very helpful. Let's start out with some of the symptoms of cervical cancer for women. What should they be looking for? What would alarm them to come and see a doctor to be evaluated?
Well, let's start out with the symptoms of precancer, and that's there or none. So the important thing is you're not going to have a symptom that you have to get that detected when it's the precancerous point with a pap smear. So you've got to go to the doctor. Then, unfortunately, if that's been missed or for whatever reason a cancer develops, bleeding that is irregular, a discharge that's unusual, bleeding after contact with the cervix, i.e. intercourse, or if a person douches, any contact with the cervix might cause irregular bleeding. So by then, unfortunately, there's already probably a lesion or an abnormality, which doesn't mean that you shouldn't respond to that quickly, but you know, of course, the late symptoms we don't want to think about with the evidence. Those would be the symptoms of metastases. But you know, hopefully we're way ahead of that with the conversation we're having today. But that would be, of course, the failure to thrive, pain, new lumps or bumps. But mainly it would be contact bleeding or just irregular bleeding or discharge.
And when we were talking about, obviously, prevention and routine screening and getting annual checkups, right now the recommendation for women to start seeing a gynecologist and getting, or through their primary care physician, is that around the age of 21 that they should establish a relationship unless they're sexually active beforehand?
Exactly, and so 21 for sure is a good time to establish a relationship. But yes, sexual activity, which is often difficult for a young woman to admit to a parent, to get her to the doctor because she isn't of age to sign for herself, that's when things get started and when, of course, the exposure occurs. And supposedly the younger woman's cervix is less vulnerable to damage, but you need to get in and be seen
And have
and
to
start sexual activity.
Sure.
Right.
So the recommendation now for pap tests, how often, starting let's say at age 21, should a woman have a pap test done if everything is normal for the first one?
So I think it depends on multiple factors, risk factors to which she's been exposed. You know, is she a smoker? Is she surrounded by secondhand smoke? Is she sexually active? Has she had many partners? Long-standing use of birth control pills has been considered a risk factor. Of course, at 21, it probably isn't that long-standing. It's probably not the pill, and I don't want to discourage anybody from using birth control pills because it does have other significant benefits in terms of cancer prevention, which is outside the scope of our discussion today. But it does imply that if you've been on the pill for a lot of years, you've probably been sexually active for a long time, therefore may have had more partners. So if the pap smears are negative for three times annually, then you can start going less frequently. There's a lot of role now for HPV co-testing. In other words, if you don't have cancerous strains of human papillomavirus, then you don't need to get it. You don't need necessarily get a pap done that frequently. But there's a lot of factors. It's hard to give a across-the-board answer. And again, you had mentioned earlier about the risks of cervical cancer in the more mature women at 65, where they're sort of told you don't need a pap anymore. Again, it depends on the individual's history and whether she's had negative cytologies, whether or not how often she needs to get them.
Okay. I think that you had started to mention just now about some of the risk factors of cervical cancer. So could you kind of tell our viewing audience again so that they know what they can do to help reduce their own personal risk?
Oh, sure. Well, I think the first thing, in many patients where we're seeing cervical cancers, most of the patients are smokers. That increases the risk of developing cervical cancer by about 4-fold. So that's important. Of course, secondhand smoking is unfortunate, and if it can be avoided, obviously avoid that. But it seems to be the coactivity, presumably of the nicotine, plus if you have the cancer-causing strains of HPV functioning together to put the patient in higher risk for developing cervical cancer. Exposure, certainly unprotected intercourse, exposure therefore with multiple partners is going to give you more of a chance to pick up a strain of HPV that's cancer-causing. And so that's a problem. As I mentioned, the long-term use of birth control pills, not because it's the pill, but it's because it means you're probably sexual activity's been going on for a long time. It is not genetic. I see a lot of people who come in and they say, well, my grandmother and mother had cervical abnormalities, dysplasias, or cancer. It's not genetic.
Okay.
So that's good to know.
Absolutely. What, if a woman is experiencing symptoms and they report them to the healthcare provider, then how is a cervical cancer actually diagnosed?
Well, the symptoms are vague and of course could be caused by many things. So the doctor, provider would presumably do an inspection of the cervix and a pap smear. So one could come in with irregular bleeding and discharge for any number of reasons. So you don't have to assume you've got cervical cancer and that all is lost. So if there's a lesion or an area of abnormality in the cervix that is seen, that needs to be biopsied. If the pap smear is normal or not, they're not going to know at the time, so it could mean a return visit for biopsies of an abnormality that can't be seen with the naked eye.
Okay. And obviously, the earlier the diagnosis and intervention occurs, hopefully the better prognosis. How do you treat, and what are the latest treatments for cervical cancer when you do see a patient?
So again, just briefly to address the precancerous conditions, a lot of women with these want to get pregnant or want at least to have the option to get pregnant. You want to preserve your cervix, which means the smallest procedure that can be done that's curative, the better. So if you come in with a large lesion and a big area of the cervix is removed, you're going to run out of cervix, which is helpful to have to become or maintain a pregnancy. That being said, if one is crossed into actually having a cancer, it's very tricky at the earlier stages to know how radical the operation has to be. Can it be something that can be treated with an excisional procedure of the cervix? Does the uterus need to be removed? So that's going to depend on multiple factors, some of which are the size of the cancer, and some of which are the grade of the cancer, what the imaging studies show in terms of whether there's any risks for, it looks like there's been a metastasis. More recently, the minimally invasive surgeries for early cervical cancer have shown that the patients don't do as well as they do if they have an open surgery. So even though having an incision that's 6 or 8 inches long in the abdomen with a hugely impacted recovery time and just much more arduous recovery does show that the outcomes in terms of survival and death is better than the laparoscopic or robotic surgeries that were done, and that's pretty recent and disheartening information because it is more impactful. But cervical cancer that is amenable to surgeries has to be done with an open incision. Now, if the disease is advanced beyond the cervix, then we start to call in other fields, i.e. medical oncology, giving chemotherapy and radiation therapy. That would just sort of depend on where the disease is and isn't, so the stage of the disease.
Very helpful. Can you talk a little bit about the importance of getting screening for transgender patients? Because I know you have a very, very broad and large practice. How important it is for patients also to be getting screening and that sort of thing?
Sure. So first of all, thank goodness there are doctors who specialize, and there are fellowships and training programs who specialize in transgender medicine. And so I would, in the ideal situation is those doctors are the experts, and if they're available to a person, I would go. But that being said, I have had, a number of transgender patients, and it depends on what their history has been. Sometimes there's been heterosexual relations before they recognized what they were or what they felt, and therefore they're at risk. I've had a number of transgender patients with dysplasia. Well, they're not sexually active currently with a male partner, but they were at one time. They did get the virus. So, and that's a very emotionally taxing issue to have to deal with, I'm sure. So I would say that depending upon what their history, exposure is, I would follow the same parameters as I would for someone who was not transgender. But again, I would be super happy to see a specialist in the area. Why not? They're there and they deserve it.
Absolutely. Is there? I think one of the guidelines that we discussed before we went live was that, at age 65, if someone has had a complete hysterectomy, the importance of still continuing to have yearly exams in general, just pelvic exams, breast exams, that sort of thing. So even though perhaps someone has had surgery, do you recommend at age 65 and older that patients still come in for a yearly routine exam?
So I have a number of patients on whom I've operated who say to me, okay, well, you've taken out my uterus and my cervix, tubes, and ovaries, so I guess I don't need to come back. And they need to see a doctor regularly because there are a lot of other things that come up in discussion or just on routine vital signs, and women may not tend to go to a primary care doctor because they see their gynecologist, just depends, but certainly an annual or every other year exam is important. Get your weight checked, urine checked randomly for sugar or other things that could indicate an abnormality. Breast exam or discussion of whether or not getting mammograms, colonoscopies, DEXA scans. So I hate to ever tell anybody, no, you don't need to go to the doctor anymore. You may not need a pap smear, and sometimes you do need a pap smear. It depends on why the surgery was done. But I would strongly encourage anybody at any age to stay in contact with their care provider.
Good information. Well, I think, being aware of your own body, knowing what is normal for you and is not normal, to obviously report immediately any changes, any symptoms or signs of anything that is not usual is so important to seek out medical care.
Right. And recognizing that a fleeting pain that never comes back, obviously you don't need to worry about. The things that you need to worry about persist and get worse. There's never going to be a spontaneous regression of a cancer-related symptom. So, a bleeding, a discharge, a pain that not only you have and it continues in terms of its severity and frequency and whatever it is, worsening symptoms, definitely something to pay attention to in general.
Great. Well, this has been very helpful. Is there anything else that we haven't covered that you would like to share with our viewers?
I think the only other thing is that it's always that transition time with the teenager to the young woman, and where does the pediatrician leave off and where do you go to the gynecologist? I think that varies with pediatricians, what their comfort level is. But I think that early gynecologic care could be obtained through the pediatrician if that's what they're interested in. If they're not interested, they'll refer them on out. But just because one is going to a pediatrician and perhaps is sexually active and not wanting to talk to a mother about it or father about it, you can still address these issues with a pediatrician.
Good advice. Absolutely. Well, thank you so much for your time.
Oh, it's
we
my
really
pleasure.
appreciate it. Thank you for joining OHC. If you want to learn more about our screening guidelines in cervical cancer, please go to ohcare.com. If you'd like to learn more about Dr. Marcia Bowling or interested in a second opinion, please call us at 888-649-4800 or visit ohcare.com. Thank you.